these are my disclosures. So you may recall this was a 73-year-old female that had previously had AF, persistent AF, cardioverted with amiodarone, so a pretty promising sign. She was overweight but had good cardiac function. So she did very well. She was discharged later on that night, and using a technique that I pinched from Devi, where we use the Z suture with a 3-way tap, so the patient's able to walk around with the Z suture loose to make sure there's no bleeding before they go home and have that taken out. The key point about the transseptal puncture was that it allowed you to introduce a guide wire before you put the needle and sheath through. And this has one significant advantage in that once the guide wire is up the left upper pulmonary vein, the chances of you pushing the sheath too far forward and perforating the appendage is very low indeed. And so that's a great safety feature, reducing your chance of tamponade. So at 3-month follow-up, she'd had no sustained AF. She was getting some palpitation, however, and had noticed that her resting heart rate was higher than it was before. So we went on to do a 7-day ECG recorder, and this confirmed that her palpitations were just atrial ectopic beats, not the AF that she'd had previously. And her heart rate had dropped from 80 immediately post-procedure to 70. And I'll be asking Julian and Devi about that autonomic modification, which in my experience and in some of the literature suggests that they're going to get a very good outcome. As we've discussed before, we continued the anticoagulants, and I again encouraged her to lose weight. And the way that I'm trying to explain this to patients now is thinking about AF as a balancing of scales, where you've got promoters of AF on one side pushing down, and some of those promoters are out of your control, like the steady advance of age. And all that the ablation is doing is trying to push the scales back the other way. But if patients don't look after themselves, eventually those scales will tip over and the AF will come back, regardless of the outcome of how successful your ablation is. Great. So we're back to Devi and Julian. Any thoughts or comments about the case or the observation of the high heart rate? Is that something that, particularly with fulguration, where we may not get the same neural effects, do you think that will be a reason for PFA perhaps not being as successful as RF or cryo?
Very interesting you bring it up. And we have also, of course, similar observation. Whenever there's thermal energy sources involved, we also see a typical rise of heart rate by maybe 10, 15 points. Patients do notice, and we believe it is associated with as a sign of often beneficial sign supporting the success of the procedure. Our observation, and this is often in line with recent publication using the Farapulse, for instance, PFA system, there's not such a marked increase in the heart rate. I don't know if you have similar experience with your PFA patients, even though after 1 year, the outcome is pretty much the same. So it's roughly 80% in paroxysmal in our Frankfurt patient cohorts. Very recently, we compared patients to cryo, and we observed a slight increase of success compared for cryo versus PFA by 3.6%. If this can be attributed to potential GP damage, structural damage, I'm not too sure, but it is at least an interesting observation. I don't know. I'm curious to hear your experiences.
I echo Julian's comments on this. I mean, we definitely see that whenever I do a thermal-based ablation and I see that heart rate response, it makes you feel good, and you know that when the patient comes back and the heart rate's back down, you feel like you might have gotten a nice durable transmural lesion, maybe affected those GP potentials, but definitely don't see that. We only have pulse field currently as part of the clinical trials, and with the limited experience with pulse field, we definitely don't see that heart rate response. Having said that, the at least in the trials when we're watching, the long-term clinical success rates have been pretty similar to our thermal lesion sets or lesion strategies. So just have to, I guess, wait and see. I definitely don't have a lot of experience with post mapping in the pulse field patients, but just curious to hear what if you have experience, Julian, on going back and remaps on some of these pulse field patients.
Yeah, we have recently published our initial experience in remapping 25 patients, and we observed a very high rate of durability of the lesions, and also the extent or the dimension of the lesions were pretty much the same as compared to what we left on an or observed in an acute phase, in the acute stage. So in total, we had an overall PVI durability rate of more than 90%, and more than 70% of patients demonstrated all veins isolated. But what was interesting, we observed scar-related or man-made related HT tachycardias running around the roof. So that was our key observation from our initial remapping experience.
So Richard, I thought it was really neat for you to use that needle, because it's almost like you don't have an exchange, and you almost zero exchange in a sense, especially in the left side, because I think minimizing exchanges in the left side makes a big deal to minimize air and any kind of thrombus. So how easy is it pretty intuitive to use that across needle with the cryo sheet? I mean, do you see that as the future?
Yeah, I mean, I found it, I mean, in honesty, I think that was my second case using that needle. So it shows you how intuitive it was. It was very straightforward. I'm used to using the safe set, which also is a guide wire that you can use through the cryo sheaths. But I definitely think that puncturing with the cryo sheath and reducing exchanges, both for efficiency and safety, has to be a way forward. And I think what you really need is a scout, like a wire, that just tells you you're in the right place before you push that great big sheath through and commit yourself. So I think it's definitely the way forward. I just wanted to ask you guys as well, whether you thought that subselecting patients with vagal-mediated AF would ever be a thing, that we would try and select them for thermal energy in the hope that this would have an impact on their vagally mediated AF. I don't think anyone's done studies on these patients, but I'd be interested to hear on your thoughts. Perhaps you, Devi, and then Julian.
It's a great question. I think, as we get more and more data from Europe on pulse field ablation, and I guess long-term effects on the different ages is how I'd say, more than, I think for the younger patient population, I feel like many a times it is vagal mediated, especially in the athletes and stuff. I feel like I would be more inclined to use more thermal energy. Probably even, I start wondering whether if we use PF energy in these patients, whether we start thinking about with things like renal denervation will show up again or not. So I'm all eyes and ears for all this. So new technology, new advantages, but we're still learning, I think, on the pulse field technology.
I like the idea also very much, because what we are lacking at this point in time is, to select our patients properly rather than being paroxysmal, persistent, or whatsoever. But still, this overall one PVI may fit for all our patients using the similar approaches so far. Is not sufficient enough. So therefore, we need to come up with smarter ideas and to identify and then intellect or smart use of the devices we can use these days. So I like it a lot. Yeah.
And do you guys have a specific risk reduction program associated with your patients, weight loss and alcohol reduction programs, or do you just leave it to them to try and do their best?
Yeah, I was going to say, I think I'm going to borrow steal this whole weight balance thing that you have, Richard, up there. I think it's a real cool way to tell the patient. I think it'll make sense to patients. But for us, we do actually enroll our patients in more of a AF clinic. they're not designated AF clinics, but it brings it brings a collaboration of multiple parties that are involved, which is, a nutritionist or a dietitian, the sleep lab, the endocrinology department. Like, so we have multiple stakeholders that are part of the clinic that actually contribute to the general well-being of this patient, and I think contributes to the better long-term success of the ablation. Having said that, you're right. Sometimes, you can talk about weight loss and stuff, but they need that ablation to get their heart and sinus rhythm before they can kind of venture into that journey. So we are pretty aggressive in helping our patients get into their weight loss journey, if that's one of the things. We're very conscious about talking to the patient about alcohol use, caffeine use, etc. in this patient population.
I think this is, of course, very, very important, and I think we all try to convince our patients to really get a more holistic treatment. But I see it in real life, sometimes difficult to keep the patient on that high level of motivation right after the procedure, maybe also before the procedure. Many patients, of course, may put a lot of effort in order to optimize the risk factors and comorbidity. But it is a difficult task to really sustain those effects. So therefore, at least in Germany, it may be a little difficult.
Yeah, I think that's true for all of us. Brilliant. Well, now back to you, Julian, for an insight on another case performed in Frankfurt by you, the single-shot pulmonary vein isolation using the novel RF balloon. Is it a new golden era?